So I'm Sharon Terry, the President and CEO of Genetic Alliance, welcoming you all to our webinar today on recurrent ovarian cancer, treatment guidance after cancer returns. We are delighted to be partnering with Travera and with Luna both to bring you this opportunity that I'm going to turn over in a second to Cliff Reed to describe. We're always happy to work with a company that's innovative, that's really putting people at the center, and that's very true about Travera. So without further ado, Cliff, I'm going to turn it over to you.
Thank you, Sharon. Delighted to be here and looking forward to presenting this kind of amazing new capability that we have around treatment guidance after cancer returns. So I'm Cliff Reed. I'm the CEO of Travera, one of the founders. And I'm joined today by Dennis Watson, who is our Vice President of Business Development. So what I'm going to talk about today is first the challenge. This is a problem that has, plagued the cancer industry for decades now. How do we select effective therapies for recurrent ovarian cancer and recurrent other cancers as well? But we'll focus on ovarian today. And I'm going to kind of describe the problem for you and then take you through sort of a very innovative new solution that we have developed. And I'll walk you through the technology without dragging you through too much physics, but it's an unusual piece of technology that I'll introduce you to. I'll then turn this back over to Sharon for her to talk about the Luna DNA platform and the opportunity there. And then we'll wrap up with some Q&A. So the problem—
Hey, Cliff, I'm sorry, just quickly interrupt you for those listening in. If you have questions throughout the presentation, please just type them into the chat and then we'll address all of them at the end.
Good.
Great. Thanks, Dennis.
Yeah, thank you. Sorry, Cliff.
No trouble. So here's the problem that's been facing late-stage cancer patients kind of forever. We have about 300 FDA-approved drugs. And those drugs are kind of given to patients according to the NCCN guidelines. And the guidelines sort of define, which stage and which drug for which patient. But all of these are developed through clinical trials, through population studies. These aren't personalized cancer therapy guidance. These are population studies. The result of the NCCN guidelines tends to be quite good in early stage cancers. Frontline treatments are largely effective, not always. Cancers like pancreatic cancer have no good frontline treatments, and most cancers have good frontline treatments. However, once a patient progresses to later stages, the treatments get less and less effective. And by the time a patient reaches stage 4, on average, the drugs work for about 1 patient in 5. So this is a very unfortunate reality of cancer treatments. And we talk to a lot of oncologists treating late-stage cancer patients, and they say, yeah, we're pretty much guessing at that point. We really don't have good knowledge of which drug to give which patient at which moment in time. And as a consequence, cancer remains the #1 cause of death of Americans who are under 85. So this is not a good situation. So the question is, how do we increase the likelihood of clinical response? Now, this is a picture actually of the ovarian cancer stage 4 therapy guidance from the NCCN guidelines. And it's a pretty amazing story. You see there are 30 therapeutic options, 12 of them considered the preferred regimen. It's 12, we know which are the 12. And then we go on to other recommended regimens and useful in certain circumstances. So this is really a difficult situation for an oncologist to understand what to do for each individual patient. So the question and the unmet need that we're addressing is, how do we find a fast and reliable method for identifying the therapies for late-stage patients that have a much greater than 20% response rate? Now, if you've been watching the research community in cancer, there have been 2 main threads of research over the last 20 years. One is in genomic medicine, precision oncology, using DNA sequencing to match patients to therapies. And the other is the immunotherapies, the checkpoint inhibitors and the CAR Ts, and all of these are really impressive new immunotherapy drugs. Well, those drugs are in this pipeline already. And again, they tend to be really interesting, in some cases really good for early stage patients. But by the time a patient reaches stage 3B, stage 4, these drugs are typically no longer available. So the problem remains. So there's been many attempts, dozens of attempts over many decades to sort of solve this problem in the most obvious way possible. And the obvious way possible is, let's just try the drugs on the cells. Let's do in cancer what works so well in infectious disease. You take the disease cells out of the patient, put them in a lab, apply different drugs to those disease cells, measure which ones work best, and give that one to the patient. That works for about 99% of all patients who have bacterial infections. And it's never worked in cancer, despite many, many tries. And the way that it's always been tried is by growing cells, culturing cells into 2D cell lines or into mouse models, and the new method, culturing cells into organoids. But it's never worked. And we can explain with reasonable accuracy why this doesn't work. And the fundamental problem is one of timing, okay? Turns out when you take 5 cancer cells out of a cancer patient, unlike bacteria that love to live in the laboratory, cancer cells do not like to live in the laboratory, right? And typically for solid tumors like ovarian cancer, take solid tumor cells out of the cancer patient, they're dead in 3 days. They just die really quickly. The problem is when you apply cancer drugs to cancer cells in the laboratory, it typically takes about a week for the cancer drug to kill the cells. At least 5 days, sometimes even quite a bit more, but about a week before you really get a good readout. So you have this fundamental timing problem. The cells are dead in 3 days, but the drugs act in a week, right? So every previous company has solved this in the same way. They've extended the life of the cells. And they do that by growing the cells. And this turns out to have a very unfortunate consequence. And that is that the act of keeping cancer cells alive kind of unnaturally in the laboratory, it causes them to change. It causes them to change genotypically and phenotypically, and it causes them to no longer respond to the cancer drugs like the cancer cells in the patient were responding. They're still cancer, but they're a different cancer than what came out of the patient. And so the testing of drugs no longer reflects what's really going to work inside the patient. That's been the fundamental problem with this sort of obviously good approach. It just no one's ever had the technology to make it work. That's what we've done. So we have changed the timing of this kind of testing, and we've changed it by enabling instead of extending the life of the cells to match the timing of the drug, we've done the other direction. We've shortened the timing of the test to match the life of the cells. And it's really that simple. But we do our test in just 24 hours. It's actually a 2-day turnaround time test because it's 1 day to get us the cells via FedEx and then 1 day of testing. So we're doing all of our testing while those cancer cells are still happy and healthy and kind of tricked into thinking they're still inside the patient, that they're not fighting to stay alive inside the laboratory. Right. All right. So I'm not going to drag you through too much technology here, but I want to give you just a glimpse of how it is we can do that. I mean, what enables us to run a test that's so fast that we can test the cells that are just like the cells that are inside the patient. And here's a very complicated slide, but I'm giving you basic ideas here. So this is based on a new invention at MIT, a breakthrough measurement tool invented in the Koch Institute of Cancer Research at MIT in the Manalis lab. And you see actually a picture of the invention right here on the tip of a finger. It's a tiny little chip. It's manufactured in a semiconductor fab. And what this tiny little chip can do is it can weigh single cells. That's it. It just weighs cells. And we can pump single cells through this chip and weigh them. We can pump about 500 a minute through this. We get these very accurate measurements of the weight of the cell. And the power of this chip is that the accuracy of the measurement is extraordinary. This is what the breakthrough is all about. In fact, when we weigh a single cell, we can detect a change in the mass of the cell or the weight of the cell that corresponds to the change in the diameter of the cell of about 5 nanometers. And if you remember, the wavelength of visible light is about 500 nanometers. Everybody else who weighs cells does it by taking pictures of them. This measurement tool is about 100 times more accurate than any microscope-based measurement tool could ever be, just due to the laws of physics. So by getting these exquisitely accurate cell weight measurements, it enables a whole different research approach to matching cancer patients to cancer drugs. So MIT and Dana-Farber, over the last decade, collaborated sort of ask and answer the question, we know that these cancer drugs are going to kill these cancer cells in the lab in a week. And we also know that dead cells weigh about half of what live cells weigh. But what happens in the first day? Might it be that by applying an effective cancer drug to a cancer cell, and just one day later, would the cells have shrunk by a tiny amount, previously too tiny to measure, but might they have shrunk by a tiny amount that we can measure for the first time? So MIT and Dana-Farber did a decade of research on this, and it turned out extraordinarily that works across almost all cancer drugs, and it works across almost all cancers. And if you think about it, what is the unifying principle of every different cancer drug, regardless of their mechanism of action and their protein interactions and all the complexity associated with cancer drugs? The unifying principle of all cancer drugs is they kill cancer cells. That's it. And so we're measuring the direct killing of the cell, but not taking a week to make that measurement, which has never worked before, doing it in one day. And just to give you a description for any of you who've actually been in laboratories, get an idea of what we do. Here's how we actually make this measurement. So we take live cancer cells, and we need about 5,000 cancer cells to test a single drug. We've done panels of 20 drugs, but here's the description for a single drug. Take 10,000 live cancer cells, split them into two groups of 5,000. And on this picture that you see on the right-hand side of the slide, put 5,000 cells into the blue cup, put 5,000 cells into the gray cup. Add drug to the blue cup. Keep all other conditions identical. Don't add the drug into the gray cup. Right? Everything else is the same. Wait for 24 hours, and then weigh each individual cell in each of the two cups. Don't weigh the cups. Weigh the individual cells in the cups. And what you get out is what you see there in the bottom right of the screen there. Is you get these weight distributions, because the cells all have slightly different weights. But you get two weight distributions. One weight distribution of the cells that were drugged, another weight distribution of the cells that were not drugged. And if those two weight distributions are basically the same, drug isn't doing anything. Those cells are resistant to that drug. But if those two weight distributions have shifted by a really tiny amount, but amount we can clearly measure now with this fancy new measurement tool, then we know that that drug is starting to kill those cells. It'll kill the cells in a week, but it's starting to kill the cells. And we figured that out while those cells were still happy and healthy. That's what we're doing. So it's an incredibly simple approach to measuring the response of cancer cells to cancer drugs, just by seeing if they change their weight in response to the drug, which incorporates all of the genomics and the proteomics and the metagenomics and the epigenomics and all of the enormous complexity of cancer biology. But we do it with a very simple piece of physics. We just weigh the cells. So the great question then is, how does it work compared to patient responses? Does this laboratory measurement predict accurately how patients actually respond to drugs? And I'll say we have not very much data yet. Okay, and if you see on this slide, you'll notice that we have only been able to test so far 55 patients, and those have been split across multiple myeloma and AML and solid tumors. And the solid tumors have been split across non-small cell lung cancer and breast cancer and ovarian cancer and pancreatic. So a very, very small data set, but an incredibly promising data set. Because of the 55 patients we've tested, and by testing, what we mean is we get the patient's live cells sent to us overnight. We run a panel of 20 drugs against those cells. The oncologist gives that patient one of the 20 drugs that we tested. And then months later, typically through a PET scan, we find out, did the patient respond or not respond to the drug? And then we compare our prediction based on our laboratory measurement. Do we predict the patient will respond or not respond? And by comparing our predictions to the actual outcomes across 55 patients, we got 46 of them right, which is better than 80% predictive accuracy. And you can see we actually predict, when we predict a drug will work, it works 80% of the time. When we predict a drug won't work, it doesn't work 80% of the time. So for a late stage cancer patient, that's an extraordinary thing, because right now, the likelihood, using the NCCN guidelines, of the patient's next therapy causing a response is about 20%. If we test the drug and we say, aha, this one's going to work, then the likelihood of that drug working, that next treatment working, is about 80%. Now, there are many limitations to this. We're not predicting depth of response. We don't know that. We're not predicting duration of response. But what we are saying is the notion that your cells are completely resistant to this drug, we're going to catch that. And we're going to be able to say, don't try this drug if if we see no response in the lab, we're going to say, do try this drug because we're seeing a strong response in our lab. Okay, so that's the basics of what we're doing from the testing perspective. And I think with that, I'll switch over and start describing the partnership. So we're delighted to have entered into our partnership with Genetic Alliance and Luna DNA, and they're working, and Sharon will tell you more about this, in developing an ovarian cancer database. And through this partnership, we're making this test available to you free of charge. We call this our early access program, and we are very early in the clinical validation of our test. And so any patient that would like to participate in this free of charge, is going to get our therapy guidance back to them, but also provides us some real value, because our ask is that we get your clinical outcome. We want to run a test and then find out if we were right or wrong in predicting, and add that into our clinical evidence basis so that we can be more and more confident about how predictive our test really is. Okay? So we have a HIPAA compliant survey. It takes about 10 minutes to complete. So if you're participating in this program, you'll get a link to that survey in a few months, and we'll ask you to fill it out. So who qualifies for this test? Well, first of all, you need to be in a position to go on a new therapy, because we're going to predict the response of a new therapy that's coming up. Secondly, we have to have access to your live cancer cells. There are a lot of ways to do this. We can get a malignant fluid from either a pleural effusion of the chest cavity or an ascites of the abdominal cavity, or we can get tissue sample. And the tissue can come from a fine needle aspirate, from a core needle biopsy, or from an excisional biopsy, a surgical biopsy. Most of the tissue we get is through needle biopsies, though, because that's what late stage patients typically get. Unfortunately, we cannot use any kind of an archived specimen. So we can't, FFPE specimens or frozen, even viably frozen specimens. They don't work. These cancer cells are so fragile that we need an absolutely fresh tissue, and we need it sent to us overnight via Federal Express. This is a CLIA certified laboratory and a CLIA certified test. And so it has to be ordered by a treating clinician. Okay? The patient, you cannot order this yourself. You have to have a treating clinician order it. And we're very good at talking to treating clinicians and walking them through the process and answering their questions. Dennis in particular does this all the time. And so if you get interested in this, Dennis will talk to your clinician, and we'll make sure that all works well. We're CLIA certified in all the states right now. Our CLIA certification in New York is still pending, but we can do, with a pre-authorization in New York, we can even operate in New York. So this is now available everywhere in the United States. So I want to just summarize, and then I'll turn this over to Sharon for describing the Luna DNA program. So this is free of charge through Genetic Alliance. The physician has to write an order for the test, and we have to collect live cells. Biopsies for Travera are not reimbursed. They're not paid for. So we want you to have a biopsy for some other reason, and then have part of that biopsy sent to us. Okay, and this can be tissue or a malignant fluid. We have a standard shipping kit that has a FedEx label on it, and so we just need whoever's doing the biopsy to put the liquid into our vial, which is inside the kit, and put it in the kit. And send it to us via FedEx overnight. We'll then test up to 20 therapies, depending how many cells we get. And actually 4 immunotherapies, which is another program that we're running at the moment. We'll test them against your live cancer cells. And the turnaround time is about 2 days. We report the results back to your physician in a CLIA certified report. And this will give the assessment of those 20 drugs. You can then use that information as part of the decision for your next treatment. And then at some point in the future, you'll be asked to tell us, how did it go? How did you respond to that therapy? Okay. So with that, I'm going to turn this over to Sharon to describe the Luna DNA program.
Great, thanks very much, Cliff. So Luna, which is a company that has created a technology that does what we really want to see done, which is to allow communities to actually keep control of their data and to find new opportunities to interface with cutting edge companies like Travera and Genetic Alliance together have created this cancer innovation community on Luna's platform. Luna's platform is everything compliant, so GDPR and the 18 states that have high privacy regulations, as well as an easy to use interface that's very secure. And so what you're seeing here is a screenshot of the portal for the cancer innovation community. And you might ask, so why aren't we just having this all a straight interface with Travera, which you can do. But for some communities, particularly ones that are serving under-resourced individuals, so this might be in the African-American or Latina community, or for example, Jewish communities, because this kind of cancer is more prevalent, and there's certain ways that they want to manage that. The Luna provides a space for that community to come together. And so you would sign up in Luna, and we'll show you that on the next screen, but you'd see something like this Travera test opportunity there in this brand new cancer innovation community. Next slide. And so very simple interface, one that you're very familiar with now. When Luna started doing this in 2019, there was still a little bit of uncertainty around things like something called 2FA and email verification. But those are the things we're all doing now in order to set up an account with our bank or any other kind of secure system where we don't want to be hacked or lose our data. And the system's quite simple. It'll ask you a couple of questions like creating a password and where you live and how old you are. The system is for adults only, and so the age is important. It's fully mobile responsive. There's not an app for your phone, but you can answer the questions and answer the surveys and so forth on your phone. Next slide. And sorry, that might have been actually, could you go back? Does that actually scrolls in the, okay, that's okay, go. Oh, is there a video? There's a video here. Sorry, if you could click that. Yeah.
Video?
Yeah. And I don't know if we'll hear the sound. So this demo is showing us how simple it is to sign up and put in the password, creating your password and confirming it, putting in your country of residence. It is international, so you can join from anywhere in the world. Putting in your birth date and then creating an account. And you can also create an account for a minor, since this is just for adults. And this two-step authentications here where the person registering is giving their phone number, and that's where the codes shows up on your phone. And then you can take that phone number and add it to the portal so that you can verify your account, and then you can look at the consent, which is quite simple, very simple one, and then join the study. And once you click join the study, you'll see some surveys, and you might have an interest in taking, for example, the general, we're using a demo here of a skin health survey. You might look at that. You might look at the Travera test survey. You might also decide to answer the demographic survey, because that helps us very much understand whether we're seeing differences in populations. Okay, next slide. Thanks, Cliff. And as I said, then you'll be looking at your own dashboard. You'll be able to upload a DNA file. You'll be able to upload your results from the Travera study or any other study you've been in. And then also you can connect your EHR from 700,000 portals in the world. This helps companies when they come here to do research, obviously, if they have some sense of what you have been through in terms of your treatments. It also helps your community if you want to start to look at what is our community experiencing and how do we actually start to be responsive ourselves to what might be opportunities for our community. And there is an opportunity here also for the community itself to set up its own community on Luna and to put in your own surveys and that sort of thing. But for now, we're basically encouraging people with late stage ovarian cancer to join the cancer innovation community and to access the Travera test. Next slide. I think it's back to you.
Great, thank you, Sharon. So this is the final summary. If you have any questions, please do put them in the chat. So the next step is to reach out to us to seek more information. And there's some links here that are shown. But you could also just contact Dennis. His contact information is on the next slide. And Dennis will work with you to answer any of your questions, outline the clinical process, and then very importantly, communicate with your clinician so that they are completely comfortable and understand what they need to do to have you participate in the Travera Early Access Program. So if you have any questions, say put them in the chat, or if any of this is sort of, it went over, you didn't notice it, or you forget about it tomorrow, please just reach out to us. You can call Dennis directly at the number you see on the screen, or email him at dwatson@travera.com. We very much look forward to talking to you.
Great. Thanks very much, Cliff. And we will send you who are registered a PDF of the slides, and this will also be in the Genetic Alliance YouTube archive to look at any time. And so either, again, you can write in the chat, or you can unmute yourself and ask a question live. That would be fine as well. And feel free to ask. There are no dumb questions here. I certainly asked Cliff and Dennis a lot of questions when we were starting to learn about this incredible technology. And so we're happy to hear your questions as well. I'm going to ask a question, Cliff, while we're waiting to see if there are any questions. And that is, we've had a couple women ask us, how hard is it to coordinate with their clinician so that they can get the sample to you, as you said, in a timely manner and fresh and so on?
And Dennis, why don't I turn that over to you, because you're so experienced in this area.
Yeah, no, I'm happy to take that question. It's generally not too complicated, Sharon. As Cliff mentioned, it does require a physician's order. And so generally, my approach is when a patient first reaches out to me and thinks that they might be interested in our test, I have sort of a standard email that I send them that takes them through the steps and says, this is what you need to know. This is what the test is and what it isn't. This is kind of how everything works. And then as part of that email, I actually offer a draft email that I just put on there as an attachment that actually came months ago from another patient we were working with. And she offered to allow us to sort of use it for anybody that found it useful. So it's a really nice, fairly concise email that was written by a patient to her physician. And so I often provide that draft email to patients, and, they attach the order form to it. They edit one or two little things to make it specific to them, and they can just hit send. And so we try to make that piece as simple for them as we can. Because of PHI and HIPAA reasons, I can't proactively reach out to your physician for you. You have to make that connection for me first. But once that connection is made, I'm happy to discuss with the physician, the next steps. Now, a little more directly to the way you asked the question, Sharon, once that connection is established, it's really about coordinating procedures that are already happening. If a patient has ascites, for example, they're typically having that drained at some regular interval, whether it's, monthly or daily. That's a really easy specimen to work with. It tends to contain a really robust set of tumor cells, which works well with what we do. And that's fluid that otherwise is kind of just tossed away. And so it's easy to once we have the order to get that into the kit. We have patients that even do it at home on their own once we have the physician's order. And if it's related to tissue, the doctor coordinates a biopsy or maybe there's another debulking surgery coming up, something like that. And then I just work with the interventional radiologist or the surgeon or whomever to get them everything they need, make sure they know what to do. And it's a fairly simple process. The doctors that are performing it don't have to do a lot different. We provide vials. They basically take out when they're doing that surgery or that biopsy, and instead of putting it into what they normally put it in to send to pathology, they send one core into our little tube or two cores, and then they drop it into our test kit, and it's already pre-labeled for FedEx.
Great. And Laura's question then, does the doctor have to oversample the tissue so that your test and the traditional test can be done? Speak a little about that.
Sure. Not necessarily. It's a great question, and it kind of depends on, how you think of oversampling. But, if this is a surgical procedure, which often for, later stage ovarian cancer patients, they might be just having a debulking. There tends to be plenty of extra tissue available for that. We don't need much. We ask for about 150 to 200 milligrams of tissue, which is a pretty small little chunk. If they're doing a biopsy with a core needle or a fine needle aspiration, we generally just ask them to take an additional quart or two. And which really isn't a lot. Especially with ovarian cancer, we tend to get pretty successful specimens. Different cancers yield different results, but ovarian cancer tends to have a pretty high yield. So I've certainly seen us get, in the millions of cancer cells from a single 19 gauge needle core. And as Cliff said earlier, we really only need about 100,000 cells to run our full panel.
Great, thank you. And another question that I thought of, having just been through, in fact, the death of a family member from ovarian cancer, is timing. So as she went through the different therapies she tried, I noticed you had a statement about the window kind of where you'll want to have this test. And so can you speak to that as well?
Yeah, absolutely. And I, this is an area that's personal to me as well. I lost my mother-in-law to ovarian cancer almost 7 years ago now. So I completely understand the challenges and complications that occur with this disease. But the ideal place to send us a specimen is at a point in time where you're about to initiate and or change a therapy. The main reason for that is that as your body and your cancer responds to different therapies that you've been on, the cancer can change. You might get a drug that's responsive to parts of the cancer, but not all of it. And so ideally what you want to do is get that fresh sample at the point in time that you're looking to make a change in therapy or initiate a new therapy, because we want to get the samples in their current state. And because that's what's going to really show us what these cells are most likely sensitive to. And I think it's also important to note, Sharon, that we're not running some crazy drugs here. We're running a 20 drug panel in most cases. But the doctor is not going to get a list of a bunch of drugs that they would just never consider for ovarian cancer. As Cliff showed earlier in the guidelines, there's a long list of indicated drugs to choose from. But if you've already been through 2 or 3 lines and you're not ready to stop and you're ready to try something else, the question becomes, of those 30 available therapies, which one do we do next? And that's where a little bit of a guessing game comes in. And our goal is to help limit that guessing. If you've got 30 drugs to choose from, let's test 20 of them. And let's tell you which ones your cells were sensitive to and which ones they weren't. And let's try to increase the rate that the next drug you go on is going to elicit a clinical response for you.
So essentially, instead of having the woman's whole body be the testing ground for the next potential agent, and maybe be wrong, because if there's a chance in 1 in 20 that I'm wrong, it's really a lot of suffering for no reason. And this pinpoints that, so that you're, again, as you said, testing the cell, not the whole person and the cancer in the body.
That's exactly right. I mean, when you get to that phase of therapy, right? What the data shows is that the likelihood of finding a clinically responsive drug on 3rd line, 4th line therapy is about 20% at best. And so the challenge as a patient is that the only way to know if this is the drug that's going to work for you, the traditional way to know is to try it. And they put you on it and they monitor you for a few weeks or a month, and then they're doing scans and they're looking for response indication. And and if it's working, great, let's continue. If it's not working, we move on. The complicating issue there, however, is that takes 2 things. The first thing is time. and you waste weeks and potentially months on a drug that may or may not be effective for you. And the second thing is that it takes a toll on your body. And so the idea is to find the most effective drug as fast as possible so that you don't have to waste that time and waste that toll and trying something that might not work for you. So 20% likelihood of finding a responsive drug going out of the guidelines and based on the data that's available. Our predictive accuracy as it sits today with fairly small numbers, but encouraging, is at 84%. So there's an 84% chance that if you go on a drug that we say is going to work, you're going to see a clinical response from that drug.
Fabulous. Great. So any other questions? All right, well, as Cliff mentioned, Dennis's contact information is on the slide, dwatson@travera.com, and his phone number is there as well, 502-552-0392. We will send these slides to you and they'll also be in our archive. And I think I find both Dennis and Cliff very approachable, so feel free to reach out to them both about yourselves or your community, because we really do want to see ways that this can get better integrated into the plan of care for people who are suffering from, as they said, late stage cancers, and particularly ovarian for this webinar here. I want to thank you, Cliff and Dennis, and give you any last words if you have any.
Last words. Thank you, Sharon. I thank everyone who's going to be watching this either live or recorded, and we hope you will reach out to us to learn more.
Great.
All right.
Thank you. Have a good day.
Great. Thank you. Bye-bye.
Bye.